All right, and when you can let this picture show while I introduce Epic and then who's sponsoring it. And then when I go to introduce you, Linda, you can just start switching it right over.
Okay. It looks like it's 11:59, so I'm going to go ahead and start the broadcast.
Hello, everyone. Welcome to the Epic Breastfeeding Training. This is the second in a series of 4 calls. My name is Tina Cardarelli, and I'm the State Breastfeeding Coordinator. And I'm very happy to have you join us today as we talk about the subject of supporting breastfeeding in physician offices. So EPIC is a training that stands for Educating Physicians in Communities. And it also talks about educating physician offices as well. And so we're just looking to raise the bar here through this series of education. This webinar is brought to you today by Indiana Perinatal Network in collaboration with the Indiana Rural Health Association and the Indiana Breastfeeding Coalition. It is being sponsored by a grant from the Indiana State Department of Health. I'm really excited to have 2 speakers today who have worked in physician offices or are working in physician offices. They're doing quite a bit to improve their breastfeeding care and services. And I want to introduce our first speaker, Linda Ebright, who is will share with you some of the lessons learned and the work that they have done in their office to improve their services. So I'm going to turn it over to Linda. Thank you.
Thank you, Tina. Just take me a moment here to bring up my presentation. I'm going to say I'm down in Bloomington, and it sounds like there's a pretty nice thunderstorm rolling in, so you might hear some of that in the background.
Linda, I just wanted to, I forgot to say that if people have questions during your presentation, they can hit the chat button and type in questions, and they will be answered at the end of the presentations. Thank you.
Okay, so my name is Linda Ebright. I'm a nurse and an IBCLC down in Bloomington at IU Health Southern Indiana Physicians, Riley Physicians. Riley Physicians is comprised of 5 offices in South Central Indiana. There's 3 in the Bloomington area, 1 in Martinsville, and 1 in Bedford. So there's a total of 19 pediatricians and 10 nurse practitioners at all those offices. I primarily work in the Bloomington offices, but occasionally a mother will travel from Martinsville or Bedford for our services. I am one of 2 nurse IBCLCs, and Esther Briggs on the left is also a nurse practitioner and an IBCLC. Esther has many other duties in our practice, so she does not often do lactation visits, but is available to help Anna and I out when we get overly full or one of us is out of town. So when Tina asked me to do this webinar, she said she wanted me to present the real world challenges we've faced as we've built our lactation program. Well, one of the first challenges we faced might seem like an obvious one, but it took us some time to figure out. As an IBCLC, you need a schedule. When I first began providing lactation services, I was trying to balance these new duties along with being a regularly scheduled nurse. So it wasn't long until it became obvious to everyone, particularly the other nurses, my coworkers, that this was not working. They were struggling to cover my duties as I was always being pulled unexpectedly into rooms. Also, I might get asked almost simultaneously to see 3 different babies who were in the office all at once. And that really didn't lead to good care. I was just bouncing from room to room. Babies and the process of breastfeeding just can't be rushed. If you've had a baby, you know that. But that is especially true when there are feeding difficulties. So as you can see, my schedule allows for 90 minutes for each dyad. And while that is a long visit, I will tell you sometimes it's not enough. I often work over into lunch or the end of the day. So why does it take so long? What are we doing in that room? Well, we start by taking a thorough history for both mother and baby. If a mom is having milk supply issues, that history becomes particularly thorough because we're trying to figure out why. We want to hear about the birth because a difficult birth can certainly disrupt the initiation of breastfeeding. We check the baby's weight. We might do a Billy check as needed. We have to observe a feeding, and that can take anywhere from 10 minutes to an hour, and it's probably going to take longer when there are difficulties. Throughout that time, I'm demonstrating and mom is practicing positions and techniques that hopefully improve the latch. We do a breast assessment. We do an oral assessment on the baby. If it's determined that mom really is struggling with her supply or that the baby cannot transfer the milk, she might need a pump, and that takes a while. We have to fill out the paperwork. I need to show her how to pump. We do a flange fitting to see which flange will give her the most milk. So that entails a lot. And if the mom is pumping, we have to figure out the alternative method of feeding. And believe it or not, there is actually a lot to learn about bottle feeding. Many people feed their babies way too fast with a bottle. So we teach parents how to slow it down, monitor their baby's sucking and breathing patterns, and follow the baby's cues. And then of course, sometimes it just takes a while to wake a baby, soothe a baby, reassure a crying mom. And I always love it at the end of the visit when I think we're wrapping up and she pulls out her iPhone and brings out her list of 20 questions that she wanted to make sure she didn't forget to ask. So what else do we do? Well, we joke that we've kind of become a lactation hotline for Bloomington. The nurses will take questions throughout the day from breastfeeding mothers and send us their phone numbers, and we try to call them back as soon as possible. Anything from plugged ducts, back to work issues, engorgement, can I take this medication while I'm breastfeeding, et cetera, et cetera. We do follow-up phone calls for the mothers and babies we have been working with. We document our visits. We do take a good bit of time to collaborate. We need to run the feeding plans by the pediatrician. Sometimes we need to contact mom's OB. The baby, if there are feeding latch difficulties, might be seeing a physical therapist or a speech therapist. So there's a lot of interdisciplinary collaboration there. We need time to stock supplies, purchase them. We design our educational materials. And then everything in italics, you'll see I get help from my intern. She helps me keep the materials stocked. She can help me with weight checks. Because sometimes a mother doesn't need another whole lactation visit. She just needs to know, is the feeding plan working? We do pump suction checks. I purchased a suction gauge, and working moms can run in for a quick visit to just make sure their pumps are functioning well. We wash and sterilize supplies. We have to run back and forth for pumps at the hospital. So I love my intern. That was a great problem-solving solution there. She is from the IU School of Public Health. We get a new one every semester, and I would highly recommend if you're in a university area to take advantage of that. So what are the benefits of having lactation support in the pediatric office? Well, there are many. Obviously, the pediatrician's office is where mom and baby come to for regular visits in the early weeks postpartum. They'll come to their newborn well check approximately 48 hours after discharge, and they'll come to the 2-week well child check. And then a lot of times in between, there's additional weight checks and bilirubin checks as needed. Sometimes we can coordinate the doctor's visits with one of our lactation visits, and that's always nice for parents. And obviously the baby is the more fragile patient of the dyad, and so collaboration with the pediatrician is an essential part of the care. So I got these stats off of the CDC 2014 breastfeeding report card. And as you can see, 81.9% of mothers in the United States initiate breastfeeding. So what that means is that the vast majority of mothers, they really want to breastfeed. But when we look at the rates at 3 months and 6 months, it's significantly lower. 46% at 3 months are exclusively breastfeeding, 25% at 6 months, and at 1 year, 34% of babies are still breastfeeding. So what can we do to help more mothers reach their breastfeeding goals? And I think it's really important to understand the prolactin receptor theory, because this is one big reason why those first 2 weeks are so important. Throughout the breastfeeding relationship, the golden rule is that you have to remove milk from your breast in order to make more. But there is evidence to suggest that the first 2 to 3 weeks postpartum are indeed a critical period in which every time a mother removes milk from her breast, she is actually laying down more prolactin receptors within her breast tissue. So if prolactin's the key, she is laying down the keyholes. And this sensitivity becomes very important when her prolactin levels naturally decline in the later weeks and months. So by helping moms in those early weeks, we are helping her to protect her choice to breastfeed. So formula will always be a choice. In our country, it's probably always going to be available should a mother need it or choose it. But in order for a mother to truly be able to choose breastfeeding still at 3 months, 6 months, or a year, she may well need that help during the first 2 to 3 weeks of her baby's life with improving the latch and pumping. And this is an idea that I have tried to share widely with the nurses that I work with, because they're the ones taking moms and babies back to the room and asking about breastfeeding. So I think this idea helps staff to understand why it is so important that we have lactation consultants in the pediatric practice, because that's where the mothers and babies are regularly coming during that critical period. And honestly, when you're a mother and you walk into a medical setting and they have a staff person there who will spend this time with you to help support your choices and to give you that support, they feel very cared for. So this is a really nice way for parents to enter into their baby's pediatric practice. So that's all the upside of having lactation in the pediatric office, but there is one downside, and that is billing. We do have some issues with billing because the Affordable Care Act does indeed list breastfeeding support and counseling from trained providers as a preventative care benefit, but it is listed for the mother. It does not mention the baby. This is an oversight that I do hope gets fixed one day. And what this means is that I cannot guarantee the parents that my services will be covered by their insurance. Some insurance companies have been good about covering the charge and not making a big deal about it being billed under baby, and others haven't. And then there's some that are completely patchy. They might cover it for one family and deny it for the next. So for the most part, families have met their deductible already just by having a baby in the hospital, and so it's often not even an issue. However, if being January, I was going through a lot of cases where the baby was born in December, but they needed lactation help in January, so this is not always the case. I'll just quickly run through the billing codes we use. For the ICD-10 codes, there are a lot that we could use. We could use jaundice, we could use weight loss, but we have found that it's just simple to use the feeding problems of the newborn under 28 days, feeding difficulties over 28 days. It simplifies it and it works. For the procedure codes, we use health behavior assessment and reassessment. They're both billed in 15-minute increments, and you can see on the slide the cost of those. And I want to point out that these codes are specifically used for when the IBCLC is an RN. If the IBCLC, like Esther in our practice, is also a nurse practitioner, her time is billed as a provider. So this has led a couple times to a few very expensive visits for families who have not met their deductible. As you can imagine, 90 minutes with a nurse practitioner is, it's not cheap. So again, as Tina asked me to talk about the challenges we've faced over the years, I naturally began reflecting on the solutions that we had come up with to meet those challenges. And so I want to talk about one of the greatest source of solutions we've had, and that's been to network and collaborate with other professionals, both within our practice and within our community. So I want to introduce you to my team. The pediatricians, of course. This is Dr. Malone, but all of the pediatricians in our practice have been very supportive to the lactation program. Dr. Malone, he has gone so far, though, to attend some breastfeeding conferences with us and even a tongue tie conference. So that's really valuable to me to get that kind of support. I feel I have a very supportive administration. You know, as I covered in the billing, it's not a huge moneymaker. And time and again, I have heard Scott Roth, our administrator, say, well, it's just the right thing to do, so we're going to offer this. And I really appreciate that. And of course, I work with wonderful nurses. But also on my team are the lactation consultants at the hospital. Of course, we work closely with them to provide moms with a continuum of quality care. This is Leah, and Leah in particular has been very instrumental in helping us address some of our challenges. So I would like you to imagine some tired postpartum parents come to their pediatrician's office for the newborn well child check, and they find out that their baby is still losing weight and that breastfeeding actually is not going well at all. And then after a visit with me, we determined that mom needs to begin pumping. And so at that point, after hours in our office, I was now telling them that they had to drive across town to the hospital, wait for one of the lactation consultants to come off the floor in order to rent them a pump and help them with a flange fitting. And you can imagine that was not working well for anyone, especially the exhausted mother. So Leah found a way for us to house hospital rental pumps in our offices. This saves so much time and trouble for the exhausted new moms that are already struggling with breastfeeding and staying up all night with a new baby. We also worked together with our electronic health record coordinator to allow the hospital IBCLCs a pathway to send us messages when there's a baby discharge that they are worried about, and we can follow up with them by giving them a call after discharge. Next up are the WIC ladies. These women are amazing. This is Robin. She's an IBCLC on the left, and Whitney is a peer counselor. Occasionally, I'll have a mom who does need a rental pump, but she cannot afford the $50 per month plus the $50 kit fee. That's $100, and some people simply can't just come up with that on the fly. And some people, believe it or not, don't even have a credit card to put it on. And so I will, with these parents, I'll review the income guidelines of WIC, and they often qualify. And at that point, I will call these ladies up, and I kid you not, somehow they magically find a way to clear someone's schedule and have that mom come over. Even if she doesn't get to see one of them, they find a way for her to leave that day with a borrowed pump. So they are truly amazing. This is Angie Bailey. Angie is a physical therapist at the IU Health Children's Therapy Center in Bloomington. Angie is extensively trained in myofascial release therapy, and that is a gentle form of soft tissue manipulation that helps to release restrictions and improve mobility. She teaches parents stretches and exercises they can do at home to help their baby improve breastfeeding. And as we know, the tongue is the star of the show in breastfeeding, and it is one big mass of soft tissue. So we have found this sort of therapy very non-invasive and very helpful. It's helpful after a difficult birth with torticollis, if you're debating whether there's possibly a posterior tongue tie, and other breastfeeding difficulties. This picture actually shows another practitioner working on a baby with breastfeeding difficulties. This is Molly McDonald, a local massage therapist, who is also extensively trained and experienced working with babies with breastfeeding difficulties. Molly has designed a 3-week class series called Body, Brain, and Baby, which covers infant massage, sucking skill exercises, and tummy time playtime. It's nice because parents can also meet other parents. This is Melissa Larimer, another local massage therapist. Melissa will often do home visits, which is just so lovely. She also holds tummy time classes in her practice. This particular baby in this picture, I really like this story. It's the fourth baby of an experienced breastfeeding mother. The baby was seen by a different IBCLC, and it was considered a possibility that the baby might have a posterior tongue tie. The parents wanted to avoid the laser frenotomy procedure, and so they worked with Melissa. Melissa saw the baby for 5 visits over a 4-week period. Breastfeeding improved, and laser frenotomy was kind of taken out of the discussion. So cases like these underscore the importance of remembering that while tongue ties are a real thing, there are a lot of other things that can interfere with the coordination of effective sucking skills. And body workers are really good at exploring those other possibilities. The tongue is a big set of muscles with connection points in the skull and neck area, and these soft tissue release therapies are a great way to explore and address those other areas, and babies just seem so very receptive to the work. So I am very lucky, and I know this, that I am in Bloomington, where we have massage and physical therapists who have invested a significant amount of their time and money into extensive study and training for this work. But even if you live in an area where this doesn't already exist, I really encourage you to reach out in your community and find those people who might be willing to invest in this work, because they do need to begin somewhere. This is Dr. Matt Rashi. He is a pediatric dentist in Bloomington, and when it is strongly suspected or obvious that a baby has a tongue tie, Dr. Rashi can step in and provide an assessment and even the laser frenotomy procedure if needed. And last but not least on my team are these 2 women. This is Anne Marie Neely and Marianne Martin, and they are 2 wonderful community IBCLCs and facilitators of the Milk Matters Community Support Group. And you can see the picture on the right that was just taken last week. This is a wonderful gathering that provides mothers with peer-to-peer support. The work that these 2 women are doing and the space that they provide for mothers in our community cannot be underestimated. As the CDC states, systemic reviews of peer support programs have found them to be effective in increasing the initiation, duration, and exclusivity of breastfeeding. So the skinny of it is that mothers really need other mothers. So, and currently we are working to better the communication between the IBCLCs in our office and the local OBs so that referrals and collaboration of care can be more seamless for mom. And last week at that Milk Matters group, when I went there to take pictures, and I told a mother why I was taking pictures, that I wanted to show our community and how we work together, she said, well, I needed my team to work together and communicate with each other, because a postpartum mom is just too tired to be the one to do this too. So I just want to come back to this slide about building community, because I really do visualize that every time I make a connection with another provider in order to help the moms in our community, I feel we are tying another knot in a great big net that helps us to catch more mothers and babies when they are struggling. IBCLCs are really in a unique position to help coordinate this kind of community, and not just for breastfeeding mothers, for all mothers. Sometimes mothers who wanted to breastfeed and haven't been fully successful are the ones who need the most community support. So I try to keep an ear to the ground and try to keep an updated email for all of the moms in our practice, not just the ones that I see, but anyone can send out this email, doctors, nurses, and this email lists all of the therapy groups, the exercise classes, baby massage classes, play groups, everything. You know, having an IBCLC in a pediatric medical setting is in and of itself just a great big net to start out with. But really what I have found is that no single lactation consultant in a medical office setting can really do it alone. Interdisciplinary teamwork and community support are really the keys to success, and moms feel that. So I just want to say thank you for listening, and I am going to turn it over to Katie.
Good afternoon, everyone. If you give me just a minute, I'm going to change over and put my presentation up also. Okay, my name is Katie Wolf. I am a pediatric nurse practitioner and also an international board certified lactation consultant. So I love Linda's presentation. She gave you such a great background on the work that IBCLCs can do to support our families. I currently work at North Point Pediatrics, which is here in Indianapolis. We have two offices. One is on the campus of Community Hospital North, and the second office is here off of 146th Street in Noblesville. So we do go back and forth to both offices. I am currently mainly over at our Noblesville location, but I help provide support for both offices. Certainly, I am going to tag on here to Linda's talk. I have been board certified in lactation for about 12 years now, in addition to working in pediatrics over the last 30 years. I have been board certified as a pediatric nurse practitioner for the last 8 and love primary care, love being able to support our families truly in the breastfeeding process. There's so much we can do. So what I'd like to do with my part of the presentation is really talk to you today about how we can provide a breastfeeding friendly office and how we do it here at North Point Pediatrics. I'm also going to look at some of the tips and show you that I've learned along the way that have worked to really make this possible, because it is a work in progress and it is a team effort, as Linda referred to. I really try to help provide our patients with the support they need to make breastfeeding as successful as possible. We do have 10 pediatricians here at North Point. We have 3 full-time nurse practitioners and 6 part-time. So we have a very large team, and I think we really try to collaborate and work very well together. We might ask, what is a breastfeeding friendly office? What does that comprise? What's the definition? When I really thought about this, I said, this is an office that supports moms and their breastfeeding babies by putting breastfeeding first and advocates for breastfeeding as the feeding norm. And you can see there, I've got a lot of breastfeeding terms in there, and it's really important that we look at how can we help provide that. As Linda talked to you about some of the statistics, what we do know is extensive early support can resolve breastfeeding issues earlier to help keep moms breastfeeding. I think my team, we've been great at really trying to get these moms in quickly to allow better support to help overall. I can fix a lot of things in the first week or so, which are much more challenging as time goes on. About 90% of women who do stop breastfeeding in the first 6 weeks really talk that they discontinued breastfeeding before they ever wanted to. And they report they didn't feel they had enough support to continue. So we want to be sure we're providing that support in any way possible and keep these women breastfeeding. In our area, we probably have about a 90% initiation rate with our breastfeeding moms, so it is quite large. So where do you start? First and foremost, I think having breastfeeding experts on staff in an office setting, including an IBCLC or an international board certified lactation consultant, is the optimal recommendation to have to provide support. In addition, I think extensive training for providers and staff nurses in basic breastfeeding management is the other key there, because we really know that if we can have people that are coming into contact with these families early on when they're here in the office setting, giving the correct information, supporting them from the second they walk in the door, we will have so much better success. And then we have implemented triage protocol with research-based breastfeeding guidelines for phone support, as we have very extensive triage with all of our number of patients. And I want to be sure all the nurses that are talking to our moms are looking at the latest guidelines and really helping these moms on the phone, where we get lots and lots of questions every day. breastfeeding support certainly helps build your practice, helps build the primary care setting with the reputation of being breastfeeding friendly. I think we all need to recognize the power of new moms talking with each other, especially through social media. It's amazing how these moms learn very quickly where breastfeeding is being well supported. I've had moms that told me they read about me on Facebook, that other moms have posted things. I've had moms that told me they ran into another mother at the grocery store and began talking about their breastfeeding experience and their challenges and who helped them. And I was recommended by moms at the grocery to say, hey, come into North Forty Pediatrics. They have a nurse practitioner who's also a board certified lactation consultant. So it's amazing how these things go through social media, especially. What is a breastfeeding friendly office as far as what you need to provide? I think the most crucial thing is to provide an exam room with a very comfortable chair for nursing moms. Here at North Point, I have 2 rooms in both locations that have special chairs that are more like a rocking chair, nice, good support for moms. They love to go in there. I am able to turn the lights down. We can have very nice support for our moms in these rooms. They are actual exam rooms, so certainly I have to make sure that they're not getting filled with our sick or well patients, but I have specific rooms I do use here at the office when I see lactation patients. I also have many moms that know that they are able to go use one of those rooms and sit in the nice chairs to breastfeed if they need to feed their baby in the office, which of course we promote and tell these moms, feel free to go in there and nurse your babies. Especially I think after the babies are getting their vaccines and here for well visits, I have many moms that I say to them, let's go back to the room, you've had your shots now, feed your baby, spend a few minutes, good pain relief nursing after having your vaccines. So moms really appreciate that. I also have several nursing pillows with either washable or disposable covers for the moms to use while they're feeding in the office. So several boppies are nice to have. I do have moms that bring their own also in with them, but I have several here at the office that they are able to use. I think it's really important if you're a breastfeeding friendly office to remember not to distribute formula samples to our breastfeeding moms unless, of course, it is medically necessary to supplement. So there's been a lot of research that looks at moms getting formula when they are breastfeeding and how that can interfere with the whole process unless it is medically necessary to do so. The other thing, I have supplies in my office for supporting those breastfeeding challenges that come up. I do have SNS supplies, or our supplemental nursing system, and that is where I just have a 5 French feeding tube and a couple different sizes of syringes, either a 10 ml syringe or 30, and I have written instructions for the moms and the dads to take home. So we go over using it if I need to have that. I can easily put those 2 things together and send them out the door with some supplies to help them keep breastfeeding or get their babies to breastfeed better. The other thing I do carry in the office, though it was a little bit of a process to get that going, I do have various sizes of nipple shields. They, sell for about over $9 or so at Target or other places. I was able to get some wholesale pricing through Medela, which has been great, but they are a charge item here at the office. The advantage, I think, to having them here that's been great is there have been times where I've had mothers on the verge of giving up with breastfeeding, and if I feel that using a nipple shield may help this mom and this baby, I have it right there. I can't tell you how many times I've had crying moms, got this all going, was able to get the baby to breastfeed, and they walked out the door of our office smiling and thrilled that their baby was able to nurse again. The other thing I think that's really important is that to make sure that if moms do need to use some type of bottle with breastfeeding their baby, either that it's medically necessary or they're choosing to do so, that we educate them to use a bottle and a nipple with a slow flow, one with a wide base, not the type of nipples that come with formula samples. Those are the worst for our breastfeeding babies. They're really fast flow. They are nothing like breastfeeding, and babies don't have to learn to open wide as they do on the breast. So making sure that we are supplying anything possible to keep these moms breastfeeding. I am not as lucky as Linda is to have pump rental in the office. So I have not got anything like that going here, but I do have a lot of great resources that I refer our moms to, certainly in the hospital setting, for any pump rental if I think they need to do that. Let's talk for a minute about lactation visits as related to what I do here at the office, being also a provider, a pediatric nurse practitioner. So there are a couple different types that we tend to do here at North Point. Number one is I developed what we call our post-hospital newborn comprehensive lactation visit. This is mainly for our high-risk breastfeeding babies within the first 2 to 3 days of discharge. Those are the babies that are identified already at the hospital. They're either preemies, they might be late pretermers, which are our babies from 35 to 37 weeks gestation, who are unique and special in their breastfeeding ability and really need very close follow-up. Those babies with greater than 9% weight loss at the hospital, or if they're also having Billy issues, moms struggling, first-time moms. So what happens is our physicians at the hospital try to identify these moms for me and encourage them to come see me in the first couple days after discharge. Sometimes even the next day we see them. And what's great about that is that I can do a newborn visit as far as the physical exam, and then also have a lot more time to spend with them educating about breastfeeding, seeing how everything's going, and actually doing a feeding observation. True lactation consults are for any baby or mom with lactation or breastfeeding issues. I will see babies sometimes 2, 3, 4 months out that are having unique new issues with breastfeeding, and those moms may call and make an appointment with me. The weight feeding check certainly be a quicker visit where I may do that as a follow-up or just need to see where things are. The key here is that I have been burned several times with what patients scheduled as just a weight check, which is a much quicker visit, and we all know they're probably having some issues if they're needing to come see me for a weight check. So I'm really careful in watching those. They really need to be more that extensive, comprehensive visit. I also see quite a few babies at their 1-month well visit, and that is another great opportunity for breastfeeding support. Moms usually have a lot more questions by then, and they're getting ready to go back to work not long after that. So a good time to talk about pumping and being able to continue to breastfeed. So again, the advantage I have being both a nurse practitioner and an IBCLC is I can see those 1-month-olds, do their visit, and then provide them with more extensive support. I do have a special EMR lactation template. I don't have a picture of it, but I tried to include here for you guys what is all on there. So it's a great template. We are on Encounter Pro for our EMR, which is very peds friendly and has been great, and they were able to create a special work plan for me. What I'm especially interested in certainly is looking at moms' past medical history. Linda talked a little bit about that also. I'm looking for moms that are risk for low supply, those that have had thyroid disease, polycystic ovary syndrome, any history of infertility, any history of bariatric surgery, moms that have had any past breast surgeries or procedures like biopsies, lumpectomies. All those things do give us a great deal of information about, is this mom at risk for low supply, and certainly the baby as another issue for risk for low weight, slow weight gain or weight loss. Obviously, the other things are important too. If they've breastfed before, gives me a really good indication about what happened the first time or subsequent or previous babies, excuse me. And I put all those things together and then look at the baby's birth history, the output, the feedings, and then obviously ending with a feeding assessment. As far as coding and reimbursement, I'm going to spend a little bit of time here from the provider perspective. And I can tell you guys that I get about 60 minutes for visits. And I appreciate Linda getting an hour and a half. It is really, many times I go beyond also. Sometimes I have to go into my lunch or just really keep those moms feeding and move on and see another patient. So when you look at my average day, I'm seeing patients for sick visits, some for well visits, and then I usually have 2 lactation slots a day along with 1 follow-up lactation visit. So many times I certainly feel like I'm pulled in many directions, and I'm trying to help provide as much support as I can. So 60 minutes is what we have arranged here at the office, and that's pretty reasonable for me to be able to do most days. Coding and reimbursement, looking at our ICD-10 codes, I usually do use the difficulty feeding at breast for our babies less than 30 days, and I've put those codes there for you. Or looking at infant feeding problems greater than 30 days of age. There's also a code for slow feeding of the newborn that is helpful for those babies that are breastfeeding, having very slow weight gain, needing to be followed closely. So I've had good reimbursement with that one also. Our babies that have extensive abnormal weight loss, especially early on, 12-13% loss, many of our providers, we will use this one also, and that helps cover a lot for our babies in that first week. I did talk to my front office administrative coordinator just to make sure that all this was going well from their perspective. And I can tell you that we have had great success with getting good reimbursement with great documentation and using the correct ICD-10 codes for our babies. I typically code this visit as a level 5 comprehensive visit, a 99215. When you are doing that, you do need great documentation along with it as a provider. So typically, as I said, it's a 60-minute visit. And then I have a drop-down box that has this, what I have in parentheses here, under the EMR. And I fill in how many minutes I actually spent in the room. So say I spent 60 minutes in the room. I have to document that that was greater than 50% of counseling regarding feeding, weight gain, milk supply, and specific instructions. So I have that just as a drop down. All I have to do is put in how many minutes I actually spent. Follow-up visits typically are shorter, usually 30-40 minutes. And if I have a mom, I'm doing a follow-up lactation for different issues, I will code that as a level 3 under the diagnosis I used previously, and I can add a time modifier if I need it based on how much time I'm actually spending. Looking at office resources, I think it's really important that you have a couple things on hand. First of all, there's a great source called Medications and Mother's Milk by Dr. Tom Hale, who is a researcher based out of Austin, Texas, does fabulous research on our medications and mother's milk, rates them in a lactation category from L1 through L5, and tells me, are they safe? What's the study? What do the studies show? And I think it's really important that everybody have that resource on hand. There are other great resources, certainly, that you can get. There are apps to really put on your phone or have there at the office. I also have a whole collection of breastfeeding handouts to give my moms, including building milk supply, how to know it's going well, sore nipples, pumping, going back to work, treating mastitis or plugged ducts. So I've created a lot of these. I have them on our G Drive, being able to print them out for moms and give them in addition to what I'm telling them. So have a good resource base there at your office for other people to use and you to be able to hand out to your patients. Additionally, a few things I've done here at North Point that have worked really well is we do have an office website that has a lot of great information on breastfeeding, including when to call and how to know it's going well. So it's really simple. to get on the website, and moms can have some helpful information there. I also put out monthly blog articles on breastfeeding topics. So we have a Facebook page, and our moms seem to love that. You could consider offering a breastfeeding class at your office. I did develop a breastfeeding class that we do once a month in the evening time. And I have a lot of new moms and dads and families come to that. And then what's great is they already know me. They know they will most likely see me within that first week. And it's a great connection, and they really love that. So a lot of hospitals have breastfeeding classes, but it's a really great thing if you can offer one at your office also. I think Linda did a great job talking about community resources that are out there. I think certainly you need to know what's in your area. I love my hospital breastfeeding support groups that are around, and I work very closely. I've known them all for years, and very closely as a team to refer these moms to be able to go for support group once a week and know where to send them. So I love all of that. I think in closing, what we want to remember is your breastfeeding moms and their babies, thank you so much. I love this quote here. A newborn baby has only 3 demands. They are warmth in the arms of its mother, food from her breast, and security in the knowledge of her presence. Breastfeeding satisfies all 3. And your breastfeeding moms will absolutely love you. I cannot tell you how great this program has been for us in our primary care setting, and how supported moms feel when everybody's all in the game trying to help them in the best way possible to go forward with being able to breastfeed their babies. I love all my providers. They are fabulous pediatricians, and they may come and ask me throughout the day. If they can ask me a question, if a mom they're seeing, they refer to me. I do have about 5 of our providers are trained in the fernotomy procedures, so they are able to do some clipping here in the office if we need that. So I appreciate all of everyone's efforts, and certainly I can't tell you how much these moms really love and need our support. How about questions?
I see I have one question that's come in here from one of our viewers. Do you refer moms to private practice IBCLCS?
Do you want to take that one, Katie, or would you like me to?
If you could take that first one, Linda, that's great.
There is a lactation consultant currently who is providing home visits in Bloomington, and there are times, like if I am going out of town, and I'll just sometimes identify a particular mom that I think could really benefit from that sort of loving care. She's an incredibly experienced lactation consultant. So yes, I do refer to her. We don't have very many IBCLCs with very active practices in the community currently. But yeah, if it benefited, especially if we were overloaded with patients, there's times that we've even had the nurses give out her name and number as an option if they feel like they need care sooner than they can get in our office. Every now and then, you know, Bloomington will just have a rush of babies born, and it's hard for us to keep up with everyone. So it's on an as-needed basis. The 2 IBCLCs that run the Milk Matters group, you know, we'll sometimes share I don't know why. Sometimes parents will just go to see all of us. So they just want as much information as they can get. So.
And just to add on to that for a minute, from our perspective, I'm with you, Linda. We really don't have that many in this area that are in true private practice. We have a few. But certainly I tell moms if that's what they want to go do, it is perfectly fine. I usually refer back to the hospital and have them be seen in the breastfeeding support groups, which of course are free in this area. But honestly, most of the time they come back and see me, so many times for multiple visits or phone calls if we need to do that.
And we do have some questions coming in the chat function too, ladies, if you haven't seen those.
Mm-hmm.
Katie, do you want to cover the question that asks for more detail about triage, since you specifically mentioned that in your presentation?
Yes, we have a whole, there's great, under breastfeeding medicine, there are great triage protocol books that really do a great job of logarithms for our triage nurses to go through, and they have that resource available to them in our triage area here at the office. Now, I will say they also many times will refer a question to me. So I have moms that will come and ask for me directly, and I will call them back throughout the day when I can. But if there's any question, what they do is they say, well, I'm going to send this question to Katie, and we will see what she says about it, and then I have moms my nurses give the moms a call back. So it's sort of a collaboration between a set protocol and then what I want to do separately for a particular mom based on what's going on.
I see a question here for a couple of suggestions about how to start connecting with community providers, and I'll answer that one since I kind of covered that in depth in the presentation. I'll give a couple examples. Here's one that I didn't personally do, but Esther Briggs, the pediatric nurse practitioner, IBCLC in our office, along with one of the women who runs the Milk Matters group, Anne-Marie Neely, they approached Dr. Matt Rashi as a new dentist in town several years ago, and he had never heard of the frenotomy procedure, but he was willing to listen, and lo and behold, he went for training and he started providing that service for our community. I went at some point and approached the physical and speech therapist at the Children's Therapy Clinic. I tried to find out the ways that we might be able to collaborate, and then worked with our doctors so that I had a way, to just automatically do referrals when I thought they were appropriate. So that was another kind of connection made in the community. And then again, I'll just reiterate that part of it is I'm really lucky in Bloomington. We have a great model here because there are already so many minds thinking alike in different areas, wanting to help mothers and babies thrive and succeed. So in some ways, I'm very lucky. But if you attend conferences, that's a wonderful place to network. The last tongue tie conference that I went to in Indianapolis was filled to the brim with not just lactation consultants, but body workers, dentists, physicians. So, conferences are a wonderful way to meet people who might be interested. So, and social media, that's always a great way to put word out in your community as well. So.
And I see a question here, it looks like from Julia, again about, can you name a few things that your office did early on that make a big difference in breastfeeding care? The first thing we did here at North Point, even before I came on, was they had, of course, a group of providers that really focused on breastfeeding. And they sent 2 of the nurse practitioners to the CLC, the Certified Lactation Counselor programs, which is a shorter, it's about a week-long program, and got them really trained in great basic breastfeeding management and got it all started here at North Point. And then the other things I think you can do baby steps, like get the chair, have a place, think about where you can have these moms go, start adding all the supplies in, and having handouts, the things ready. So you can start with baby steps. I've been here at North Point about 1.5 years now, and certainly I'm the first IBCLC to come in here, so as a nurse practitioner. So you can start out and you can really have some great support for moms by doing small things at the beginning and building onto your practice.
I see a question here. Do your offices give out formula discharge bag samples? And if not, how did you stop this? We not really discharge bags like at the hospital, but I think like many pediatric practices, we definitely do get free samples from the formula company. And this has been sometimes a bit of a heated debate within our office. The most recent kind of rules that we're following is there are no coupons at the front. There's no visible formula promotion anywhere in the office. And it is limited. The giving out formula is now supposed to be limited to just the doctors when they deem that it's medically necessary. Now, there are times that a mother may be exclusively formula feeding her 3-month baby. Breastfeeding is really kind of off the table now, and the baby's having some digestive issues and they have to try all these different formulas. And, in that scenario, it is, I'm sure, very helpful financially to that family to be able to get samples. But I think all offices need to have a good discussion on understanding what research has shown us, that when we give out formula samples from a particular company, in a sense, we are a marketing arm and we are helping improve their sales. I mean, the research is there to show it. So there's a delicate balance. The nurses who were upset about not being able to more freely give out the formula samples, I really felt were coming from a place of love, because for a mother, again, who's just exclusively formula feeding her baby, that is simply just baby food now. And everyone wants to help a family who's facing economic hardship feed their baby. So I do understand on an emotional level where they were coming from. But I think we always, in the role that we're playing in medical settings, we do need to understand the greater public health picture and what research has to offer us. About why indeed the formula companies are taking their time to deliver us formula, because it is beneficial to them. So there's a balance somewhere, and I feel like we're getting closer and closer and closer to really striking the very best balance in our office. I'm happy with the progress that we've made since I started working there 8 years ago.
We had another question and answer come in. It says, in Indianapolis, there is pushback from doctors about LC assessments in hospitals. How does your role in the office setting help this situation?
Katie?
I really have not found that to be the case. So I'm trying to find the best way to answer that.
I'm thinking,
back
Katie,
in the hospital settings, is that what?
I'm thinking it's probably because you're a provider and you're in a different situation, because immediately, a light goes off in my head. I understand what they're talking about there. I think that question is referring to telling someone that their baby might have a tongue tie. And that is a hard situation. If you are a lactation consultant working in a medical setting like a hospital, and you're being told by doctors or administration that you're really not allowed to say tongue tie, but the trainings you've been to and your experience with breastfeeding is really leading you to believe that this baby may indeed have one. It's a really tricky situation to be in. And again, I'm going to say that somehow I'm just very blessed. I have at least a few doctors that have been so supportive and open-minded to exploring this possibility, because there is one question you can always ask, and it's, well, okay, if it's not a tongue tie, then what else are we going to do to help this mother stop having bleeding nipples, and what are we going to do to help her baby transfer the milk? And a lot of times that answer doesn't just magically appear. So when you get to that kind of wall, I mean, I think you just have to explore possibilities like tongue tie, and the research is building. I don't think we know everything we think we know, so I do try to proceed with caution. And I realize I'm working in a medical setting, so I really try to hold myself to high standards, and not just loosely use that term tongue tie. And that is part of why I lean on body workers too, because there are other reasons, other muscles, other nerves involved with breastfeeding. There's more than just a tight frenum sometimes. And I've seen body work offer great results. And also it helps parents feel like they're trying other things, because nobody really wants to send their baby for even a minor procedure. So it's a process that I think is really helpful for parents, and it certainly doesn't harm the baby to go to an experienced body worker like the ones that I showed you. So again, I say that by reaching out in the community, I feel like has helped the way that we verbalize tongue tie even in Bloomington. So
thank you, Linda, and thank you, Katie. You've done a wonderful job. We've run out of time. I want to invite people to attend the third in the series of EPIC calls on February 16th during this same time period, 12 to 1 p.m. And we will be talking about building lactation support services, multidisciplinary, really looking at the whole community and how we can all work together. And I think this was a very good introduction to what we'll be talking about next week. So I thank you again, and we will see you on February 16th. Bye, everyone.